Good afternoon. I am Bunny Ellerin, the co-founder and CEO of DHNY, and wanted to welcome you to today's webinar, The Economics of Obesity, Making Coverage Work. The topic of obesity continues to dominate the headlines, both healthcare in general. And today's conversation is going to cover a variety of topics related to the challenges of evaluating and implementing coverage for obesity treatment. So with that, I would like to bring our panelists on. We have AJ Ally, we have Alina Bonitskansky, and we have Matt Persia. And so I'm going to ask our panelists to give a brief introduction, and then we will jump right in. So why don't we go in alpha order from first name? So AJ, you're up first.
Certainly, and good afternoon, everyone. For those who are on the West Coast, good morning. AJ Ali, pharmacist by background and a partner here at Milliman. I have a passion for making a difference in patient lives. So I work on strategic engagements to solve some of the challenges we have in our healthcare system related to cost and affordability and related to GLP-1. I think, there's a pressing need for balancing cost and coverage. So pleasure to talk to you all today.
Alina.
Hi, everyone. My name is Alina Bonitskansky. I'm the founder and CEO of Allant Health. We're a value-based center of excellence for obesity and cardiometabolic health. And our focus is really on de-averaging care to get the right member to the right treatment with the right level of support. We do that through a combination of proprietary analytics, which is some of what I'll talk to today around how do you get the right member to the right treatment to drive clinical and financial value. And we combine that with a comprehensive care team that includes obesity medicine, mental health, dietitians, and peer-based support, as well as technology to support individuals along the obesity treatment and cardiometabolic health journey. And I come at this both from prior professional experience on the health plan side, as well as pretty extensive personal experience as someone who's lived with obesity for just about ever.
And thank you. And finally, Matt.
Thanks, Bunny. Hi, everyone. My name is Matt Persia. I am the Director of Wellbeing and Engagement at NFP and Aon Company. I work with our Northeast clients on their wellbeing and engagement strategies to help employees live a happy, healthy, and more productive life.
Amazing. So we have three experts here. And, GLP-1s are no longer the new thing, right? We've been talking about GLP-1s now for a few years, as well as other treatments for obesity. But we're still in a position where those who cover benefits are having challenges. And that's why we're really talking about today, particularly the economics of making it work. So to sort of set the stage for our panelists, now that GLP-1s have been around for a few years, what are the current pressing challenges for plan sponsors related to coverage? And Alina, why don't we start with you?
Yeah, so I would say I sort of bucket this into two categories, which is I think one, folks are definitely trying to figure out, how do I make this financially viable, right? So I think no secret that the cost of treatment is high. And so a lot of, sponsors, both employers, but you saw the CBO come out with sort of a study on this for Medicare. So generally, essentially, payers have this fundamental question of how do I pay for it, especially upfront costs before you start seeing some of the reductions in obesity related conditions and the value. And I think separate but related to that is how do you make sure you are capturing value? Because I would say separate from the cost of treatment, one of the concerns we're seeing is obviously sort of people coming off treatment or not getting the treatment to those individuals that would benefit the most. And so, we're in this very, I would say, unfortunate dynamic, which is almost every plan sponsor has clearly obesity related conditions, diabetes, cardiovascular disease, musculoskeletal issues as, top condition, top three or top five. And those are growing sort of dramatically in terms of cost. We see chronic kidney disease and not, formerly known as non-alcoholic fatty liver disease, NAFLD, or now MASLD, in ages that we've never seen them in before. All of that is obesity related. So clearly driving costs, but we're sort of, the challenge is like matching the potential to reduce that cost, improve health, improve productivity and all the associated benefits with how do you actually get those right people to the treatment and sort of keep them on treatment and optimize the value of that treatment. And so I think, there's still a little bit of trying to figure out how to pull all those things together in a way that creates value and sort of near-term value to make the programs financially viable. And so that's a lot of what I see, sponsors sort of struggling with around this.
Yeah, I think it's from my view on the plan sponsor side, it's just balancing coverage with net spend. So how do they implement a coverage strategy that provides more certainty on the drug spend and an ROI? And the ROI, to get the ROI, they definitely need to make sure that the coverage is married with a patient engagement program, behavioral health modification or nutritional therapy program. That's sometimes missing. And then the other thing on the financial side is there seems to be misunderstanding on the net cost. When they implement a coverage strategy, and if it's not aligned with the PBM contracts, PBM rebate contract, there's a misalignment there that creates this, abrasion and almost cognizant dissident in terms of regret in the future years, where potentially employers may be opting out.
Yeah, and just to echo what was said, I think it's the long-term ramifications of the drugs themselves. So how long do people need to be on them? If they come off, what type of support is in place to make sure that they don't continue to bounce back to their previous weights and kind of lose all the effects, the positive effects of the intervention from a prescription standpoint. So really trying to understand what those, 3-5 years down the road, if an employer is still within an organization and they were on, or if they're still on the GLP-1s, what is that overall impact, and being able to see in the future and kind of measuring that and quantifying it so that you can budget appropriately and be prepared and make sure, again, that if people do come off, like, what happens, and having backup plans in place for them.
So AJ, you had talked briefly about net cost. For people who are not as day-to-day in the whole PBM world as you are, can you explain what that means and how that's impacting the environment?
Yeah, I mean, the reality is right now, the way all prescription drugs are priced, the patients see the list price, right? And that's the price they see at the pharmacy. There's a retrospective discount that is applied and is typically negotiated between the PBM and the manufacturer. And that discount is called a rebate. And that rebate is typically passed through to the plan sponsor. Now, how it's passed through the plan sponsor that's the place where it's opaque, where oftentimes is a guarantee, so just a per brand guarantee, but it doesn't reflect the rebate for the actual medication. It's just an aggregate number that is calculated and it's passed through in a way that's, in a very non-transparent way, but that's just the way the market works. So the employer never really see the net price of the medicine unless they do some type of back-end calculation. But the net price in this case is simply the list price less the member copay, less the rebate guarantee that they receive from the PBM is the net plan spend to the plan sponsor.
Annette, you were talking a little bit about the ancillary services. So in your opinion, what wraparound services do GLP-1 patients need to be successful?
Yeah, I think if you look at kind of what the epidemiology is for obesity and a lot of lifestyle related conditions, a lot of it is lifestyle related, right? So making sure that you're addressing the additional components that are the lifestyle that can contribute to weight gain and obesity. So things like physical exercise and activity. Are you providing tools and resources for people who are on these types of drugs to maintain physical activity and provide them with resistance strength training programs so that we don't have the side effect of lean mass loss throughout the duration of the intervention. Things of nutrition, thinking of how many calories are coming into our body, what types of food we're eating, and being able to have someone, a registered dietitian or someone that can talk to a patient in an educated way to make sure they have the right tools and support they need from a nutrition and diet standpoint. It could include some type of food or meal delivery services to get a patient to start eating healthy in the right way and understanding what proper nutrition looks like in a convenient form. I think when we talk about the prescribing of the medications, making sure it's the right provider that's built within the system that is providing the medications, to look at the patient or the employee as a whole person and understand, is this the right medication for them? Are there other medications that would potentially be more effective or better for them from where they are starting based on their history, risk factors, and things like that? And then some other things that we don't typically really think about is sleep, like sleep health. There's a really large component of proper sleep and getting restorative sleep that can impact weight gain or weight loss. And then the behavioral health component of it too, right? So there could be some underlying addiction issues with people who have obesity or are overweight. So how do you, from a behavioral health standpoint, how can you address those type of underlying issues, as well as looking at and discussing and addressing the potential stigma that comes along with obesity and some of the other conditions that we have in place these days. I think of and Alina mentioned it, there's a lot of chronic conditions and comorbid conditions that are related to obesity. So understanding if someone comes in and has these other chronic conditions, is there support, education, materials, information on how to address those conditions in conjunction with the GLP-1s and weight loss. So I think you have to look at it from a holistic perspective and understand all the different components that could impact and create someone with obesity. But then looking at that, zooming out, and then finding different ways to implement and provide additional services, tools, and resources that can address those to make sure at the end of the day that the employee and the patients who are on these type of medications are successful in the long term. And when they do taper off or they don't need it anymore, that they continue with a positive lifestyle to ensure that the weight gain doesn't come back.
Along with the right provider, as you mentioned, Matt, we kind of need to identify the right patient. And Alina, you've done a lot of work on this in terms of stratification and segmentation of populations. So what are your recommendations for identifying the right population to make sure the right people receive this treatment?
Yeah, so I would say there's just a number of challenges here we all have to acknowledge, and these challenges are not going to go away soon. So a lot of this stems from, frankly, the historical bias around obesity. So just as a reminder, obesity has only been considered a disease for about the last 10 years. That timing is approximately when we had the mental health parity. So we've talked about for years that sort of mental health is undertreated. We literally started calling obesity a disease at around the time that we said we should treat mental health and physical conditions equivalently. So I just want to baseline that and sort of where we are in the world. And I think that can be really easy to forget because of the year of Ozempic and but from an obesity treatment standpoint, we're really behind in sort of everything in the healthcare system around that. So where does this translate into? So first and foremost, it translates to a huge undercoding of obesity. So we know that obesity in this country is about 50% of the total population, give or take 5%. And then you have about another 20 to 30% that have overweight. If you look at coding, and we've now looked at over 1 million lives with suspected obesity, we'll be at about 5 million in the next couple of weeks. But in the commercial databases, obesity is coded at about the 5 to 10% level. So essentially call that 5 to 10 times undercoded. It's like moderately better in some Medicaid and Medicare states because they probably had some minor quality metric around it, but maybe coded at around the sort of 10 to 15% level. So like not just in healthcare, but in business and life, like you can't address things that you can't see, right? And we have actually fundamentally made obesity not seen in most of the classic tools we use around healthcare. So I think the primary piece is to understand sort of who has obesity or likely obesity and where is there the potential to treat and therefore not do a knee replacement or not have progression to a heart attack, et cetera. So that is the number one piece. I think the second piece is related to that. We often haven't done the studies around what is the specific impact of obesity treatment on cohorts. And so even I mentioned this earlier, Congressional Budget Office came out with some studies around what would happen if we covered, obesity treatment, particularly pharmacotherapy for Medicare. And they basically admitted in the report that like we don't have great data. What we're looking at is sort of aggregated numbers around, hey, previously when we did an intervention on bariatric surgery on whoever came in, here's the average reduction in cost associated with that treatment. And what we've actually done in a lot of our research is what we call de-averaging, right? So Matt noted some comorbidities that you have with obesity. There's about 200 different conditions that are either caused by obesity or comorbid with obesity. The treatment of those conditions has very different values in your ability to basically reduce the condition and therefore reduce the cost. So some of these should feel intuitive. So for example, the value of reducing diabetes is higher than the value of reducing mental health. Why diabetes is more directly caused by obesity, mental health is more of a comorbidity, and that should intuitively make sense. But as an example, chronic kidney disease, which I mentioned earlier, is one of the highest cost conditions. We have okay data around what happens when you address chronic kidney disease at stage 2 and 3. We have almost no data on what happens if you attempt obesity treatment at sort of CKD5 or ESRD level. And so I would say, what we've done is we've actually gone out and sort of disaggregated everything that exists and sort of said, okay, for every condition that we have, for every piece of knowledge that we have, what's the value? But there is legitimately a whole host of other areas that we sort of don't know the value on. And by the way, I haven't even gone beyond healthcare. So I haven't even talked about what is the impact on workers' comp, on disability, on productivity. If you want to stay on the government market side, what's the impact on long-term services and supports? What's the impact on the ability to, for example, Bunny brought up Medicaid, reduce the age, blind, and disabled population, some of which is potentially in that category due to obesity-related conditions. And so I think the answer is what we have to start doing because the population is so large is using the data that we have today to target and engage the highest acuity people and the highest value people based on what we know today, but also recognize that one of the impacts of doing that work is we're going to learn a lot around what does happen to MASLD, to CKD stage 4 as we do treatment and what's the incremental value there. But I think to AJ's earlier point, what's really important is to get those cohorts of individuals that we know there's value on today and make sure we engage them in treatment. And to Matt's earlier point, one of the sort of really challenging components in obesity treatment today is because of the huge shame and stigma associated with obesity. A lot of the times, the people who could benefit the most are least likely to engage because they've essentially experienced the most stigma. So obesity is a disease you literally wear out in the world. And so in some sense, the more you have it, the more likely you experience bias. And so it's really important when we think about sort of bringing all these things together and engaging the individuals where they're super high value. It is about targeting them, but it's also about creating an environment where individuals feel safe to engage and sort of get treatment for the condition.
Yeah. Bonnie, if I may add, so there's a really good New England Journal of Medicine study that was published early this year, and it talked about kind of the four tiers or the allocation of coverage into four tiers of patient population. And I want to clarify that when you think of patient segmentation, there's two uses, one for coverage and the other for certain analytics, like Alina just hit on, analytics for identifying patients to engage, analytics for measuring KPI outcomes, etc. But the New England Journal of Medicine, what I found fascinating, there was four tiers in terms of who are these four stratified segment tiers. And to tie back the coverage strategy, and I would caution that as you look at those tiers, you have to make sure that you understand the impact they may have to your PBM contract. So for example, I'm just picking one here, the broadest tier, tier one, this is actually the most narrowest tier is tier one, tier four is the broadest. The most narrowest tier would be, classified as class 3 obesity patients, right? Where they have a BMI greater than 40 and, they have severe type 2 diabetes, which are A1C greater than 8, and they have disease that hasn't responded to alternative treatment. So these patients potentially you can make a difference in preventing excess and premature death. Right, that's a very small targeted percent of the population versus the more broader population where you can just have coverage closer to the label, the FDA label of the medicine, which are BMI over 25, and you can have with or without comorbidities. And they're not, this population is much bigger. So the question is, you think about stratifying the population for coverage, you have to make sure you balance that with how that is going to impact your PBM contract specifically, and more importantly, how you design your patient engagement strategy. Because I think the patient engagement strategy, you can definitely use stratification to make sure that you get the best ROI. And we'll talk about ROI later.
Can we stay on the PBM for a bit? Because we had a question from the audience as well, and I have a question about it. It seems like there are a lot of hurdles with the PBMs and vis-a-vis employers and other stakeholders. So can any of you, but I know AJ, you're very close to this. Can you identify some of the big issues that employers are facing? And from the audience, how often does an employer go outside the big three to negotiate a contract for obesity?
Yeah, I'll start and then I'll have the team members chime in. And there's a lot to unpack here, right? When you think of hurdles, there's formulary restrictions, there's rebate guarantees, there's prescriber networks, etc. So let's unpack them. So formulary, for example, formulary restrictions. What that means is that you have to limit the coverage where these medicines are covered at parity, with the other weight loss medicines. You can disadvantage. So that's very important from a formulary perspective. In addition, you have to make sure that the member cost share is also at parity, meaning you can't have different cost share, carve out cost share for these medicines compared to your traditional plan design. If you do that, then you create a hurdle with the PBM when it comes to the rebate contract. Moving to prescriber network, I think it's important that you do have some restrictions on the prescriber network. So for example, providers who are like dermatologists and anesthesiology and dentists and emergency medicine and nuclear medicine and ophthalmology for your eyes and pathology and radiology, those docs should not be prescribing these medicines, right, for these patients. You don't want someone's friend, because I remember I had someone who actually called their friend who was, an MD that has nothing to do with treating these patients just to get a script, which was the oddest thing ever. So you do want to make sure that your prescriber network restrictions is compliant with the contract, but there are some hurdles there to make sure that is implemented correctly, because any deviation will result in rebate loss. Now, what's interesting is most recently, there has been new contracts negotiated between the PBM and the manufacturers where you have this tiered pricing where there's a little bit more flexibility where, for example, if you have a broader coverage, you get the most deeper discount rebate. And if you have a little more narrower coverage, you have less of a discount, which is good. The other component from a restriction perspective is the PBMs are giving each of the employer an incentive to enroll in their own wholly owned weight management program, right? Whether it's in Circle or Safeguard or any of the PBM programs, PBM guarantee programs, these incentives, provide a lower cost, a lower fee to, implement these patient engagement programs that are already been integrated with the PBM. From a negotiation perspective, I think the employers need to ask the PBMs a few questions. The first question I would ask is, you need to know what is the most restrictive coverage criteria that you can implement and not compromise, your rebate guarantee contract, recognizing there's two tiers, and that's fine. And then challenge the PBM if they say that if you use a third-party vendor, your rebate will be impacted. Because if that third-party vendor is specifically to help you improve patient engagement, adherence, making sure you get the ROI around covering these medication, there should be no reason why that should impact your rebate contract unless that third-party vendor is doing something that violates the PBM rebate contract. So, for example, I mentioned the two-tier of rebate contract that exists. The PBM may allow a employer to cover the medicine, for example, where it's covered to FDA label, right? And if the employer was to implement like a stepping program, like a behavioral modification program, where the patient is only eligible for coverage if they enroll in this behavioral modification program and they meet all the clinical criteria as per the FDA label, you get one discount. Versus another and a situation where there's no stepping involved, and you get a different price. The last thing I would add is that if a PBM push back on where the prescription is filled. So right now the PBM mail order pharmacies are not carrying these medicines, because of different reasons, both supply chain as well as pricing reasons. So if you think about where the medicine is dispensed, pharmacy channel, I think you can negotiate that with the PBM. And then just add a few more, I would make sure you ask your PBM for reports around measuring spend and adherence if you do enroll in their program. You also want to make sure that the PA, the prior auth that the PBM implements, it's automated with ICD-10 codes, and push the PBM to implement the PA using EPA, so electronic PA that uses EMR data. This will help with member abrasion. And then last but not least, if you negotiate with the PBM the clinical criteria, the initial PA should be at least 7 months to minimize waste, right? And then renewal PA could be 12 months as an example. So these are the little things you can negotiate and some hurdles that exist when you implement coverage. There are many more, but these are the big ones that to think about as you move forward.
I think those are great points from AJ. I just might add just one piece. I think one of the things that I see a lot of sponsors struggling with is, the reality is like the sponsor is responsible. If you're self-funded, one of the things, the reason ERISA exists and sort of enables the employer as the plan sponsor to do things is because they are taking responsibility. And so when I started, I heard things from employers like, our health plan won't give us the claims data. And I was like, no, like that's not possible. It's your data. Like they may have it for you, but it's literally yours. And so I like from a legal standpoint, like you own it, they administer it. And so I think like one of the things to recognize is there are very obviously incentives here. There's lots of things going on. There's technical considerations that everyone's addressing, but like from a fundamental, like first principles standpoint, the payer, so the plan sponsored, whether that's a fully insured plan on the government side or a self-funded employer plan, you are the fiduciary responsible. And so you actually do have the responsibility and the ability to say, here's some of the things that I want to do. And so I think that's sort of important to sort of go back to that first principle a lot of times when you're having these discussions, because there are a number of challenges, there are a number of considerations, but I think sometimes like, what is suggested and what is actually true from that sort of standpoint is a little bit different. And so I think to AJ's point, it's important to just have very like clear discussions on like, here's what I want to see, here's my questions, because like as an ERISA fiduciary, employers actually have certain rights that sometimes can get convoluted in some of these discussions.
Matt, did you want to add anything?
I just think there was some great points stated, and one thing that we're, I guess, seeing a little bit more of in the market when it comes to employers looking for solutions outside the PBM. There's definitely more exploration. I think last year, 2 years ago, when employers started covering GLP-1s for obesity indication, it was kind of like, well, let's either turn it on and do it now and just figure out what's going to happen, or we're not going to do it. We're just going to kick the can down the road. And either way, the conversations are now like, well, if we're looking to include this, like, what other solutions can we put in place to ensure that, one, rebate guarantees, and from a financial perspective, that's not an issue. Two, we're making sure, again, the right people get the right medications at the right time. And then three, that those people who are and do need the medications, that they are fully supported from a lifestyle and behavioral standpoint. So we are seeing more and more employer groups looking outside of what the PBMs offer and kind of let's carve out solutions to say, well, we know this is a bigger problem and it's not really going away. So how are we going to address it the best way we possibly can?
Well, did you want to say something, Alina?
Yeah. Hey, Bunny, just to build on that point, I think one thing that's important to remember is in the clinical studies, the medication was done alongside support for lifestyle interventions. By the way, that's not specific to medication. Bariatric surgery also works better when you do lifestyle interventions and supports alongside the therapy. And I want to be actually super clear on this because I think a lot of times this fact gets used as almost a form of bias, which says like, oh, it's because people they don't want to do lifestyle intervention. Our experience is actually people are desperate to get support to sort of improve or even maintain or actually be able to achieve some of the things they weren't able to do, whether that's like run or play on the floor with grandkids or whatever it is. And so I think it's really actually important to recognize that like the data we have actually suggests that all of these medical treatments, whether medications, whether surgery, are enablers to helping people sort of get to a place where they're able to do more. And so I think really important to consider that. And then like at the same time, it's really important that we don't sort of consider that lifestyle intervention, I would say, in a judgmental way or as a blocker. So I think one of the things that's almost like very hard to conceptualize is when we talk about obesity, we're talking about potentially half your population. Again, give or take like some percentage that still basically rounds to half. It should be inconceivable that you could treat half the people in your company in exactly the same way. Like you literally wouldn't put in place like any other policy and assume like we're just going to do one thing and it's going to work for half the company, like no problem. And so I think it's really important when we think about this sort of treatment support and even what's the right path to different treatment, that it's done in an individualized way, recognizing some of these like multi-component supports that are needed.
And actually, we had a question about what the totality of treatment includes coming off it, right? And I think there's a lot of people need to maintain. Maybe they're not on GLP-1s forever, but there are other medications they may need to be on to help them. What's your feeling about that in terms of the total care package? How should that factor into patient engagement coverage and all that?
I'll take a stack as a pharmacist. I think that's optimistic. If the patient is treated and they do receive the full behavior modification, lifestyle support, I think it's very optimistic and realistic to expect that you should see a tapering off of the medicine and where their body becomes basically a new steady state. to continue experiencing that weight loss. Now we don't know how long that will take because right now the study that is available suggests that you do gain back the weight if you stop therapy within after a year, excuse me. But I'm optimistic that we will not see that maybe in 2 or 3 years if those patients do receive that behavioral lifestyle. Now, it may not work for 100% of patients. Some patients with certain genetic pre-comorbidities, they may be more difficult to treat. They may need to stay on therapy for longer. But I think for the majority of the population, there's a hope that you can actually discontinue and wean off or transition off the therapy and use more first-line interventions. I think time will tell. I think there's a few real-world evidence studies underway. Time will tell.
Yeah, I mean, building on AJ's point, I would say when people ask me, do people need to stay on drugs for life or can they come off? My answer is yes. Which is we have half the population here. Like, I want you to pick any other condition or area where like even 10% of the population exists, and you would say like everyone here is exactly the same. And so I think the answer is the biggest challenge we have is the data today shows that some people who come off treatment are going to regain, and some people who come off treatment are not going to regain and are going to stabilize. And we don't know who's who, right? And so to me, the answer here is you've got to be able to segment. At every stage in this process, you've got to be able to segment. And so I think it is deeply irresponsible to take 100% of people off treatment if you know that 50% plus are likely to regain. And I also think it's financially and sort of personally uncompelling to keep people on treatment, any treatment, when they could be sort of sustained off treatment. And so the answer here is, I think to stop selling a one size fits all and to actually get, I think we all have to get in the nitty gritty here, which is we have a state where there's a lot of diversity in what's going on and you've got to match people. And I would say, on one hand, to this point, the fact that GLPs have become so prominent has certainly raised awareness of obesity. But I also see some of what is being sold out there around sort of everyone can be successful on this diet, or everyone can be taken off this drug to this drug, or no one can be taken off, or everyone needs X or everyone needs Y. And then I would just go back to first principles, like 50% of the population. Please find one other thing where you would say everyone who is X is Y. And so I think we've got to stop selling in some sense and buying this concept of sort of easy one size fits all solutions and get to this very nuanced, matching individualized approach that's personalized and data driven.
Yeah, I think that's where a lot of the wraparound services come into play, right? It's not just wrap around and support employee or participant while they're on the medication, but when they're ready to come off, do they still have that support? And when they do come off, do they still have that same support? Behavior change and lifestyle modification is extremely hard. I think we all kind of know this, to change behaviors and get healthier in that regards. And I think that's where a lot of the hesitation is to cover some of these medications too. It's because, well, we're just going to give it to people and they're not going to change behaviors and they're going to be on it forever. So I think that's a concern, and rightfully so, because of how hard behavior changes. But and with technology, and you support people with a registered dietitian, a mental health specialist or behavioral health specialist, someone who can help them with exercise prescriptions, an actual primary care doctor or an obesity medicine doctor that can go from a medication standpoint and look at the other chronic conditions and support them with all these professionals to give people the right tools to succeed. And those individuals, in conjunction with AI and the technology itself, can personalize the treatment protocol. I think that's why you'll see a lot of success. And being able to identify if someone is ready to come off medications, not because they lost a certain percentage of weight, but from a behavior standpoint, they're confident that they can maintain the lifestyle, the healthy habits, and they're confident and mentally in a good place to continue their journey without the medication and continue making sure that the weight stays off, and they're reaping the benefits of the medication when they were on it.
one thing I would point out is I do think there's a lifestyle component here, but I also think there's an underlying medical, condition. And so the reality is we may have some people that have the greatest lifestyle interventions and they just can't come off treatment because of where they are from sort of their personal metabolic health standpoint. So I think it's an and in many cases. And, I think we also need to be, realistic on sort of expectation. So if the expectation for someone to come off of a medical treatment is they work out 4 hours a day while eating 800 calories a day, I think that's probably unlikely to be a sustainable solution for most humans, especially if they're sort of like working or they have children or parents or, a life. And so I think what we also have to be realistic on is like, again, this like for some individuals, right, it can be an enabler. It can help you sort of then, before your knees hurt too much to actually work out, you weren't comfortable going to the gym and building muscle, and that becomes an enabler, and you get to a place and like you're in a great place sort of coming off treatment. In other cases, you may be in a really progressed metabolic health standpoint, part of, both your parents had progressed diabetes, so did your grandparents. You've had, the condition since you were, 18 years old, you're 58, right? Like, I think realistically, there's going to be situations or, with all of the greatest sort of lifestyle changes, you're still in a place where you're going to need ongoing support. And so I think it's important that we sort of consider those like very individual dynamics, and that we don't, I would say as someone who's lived with obesity, sometimes the bar was like, well, you can lose weight if you work out 5 hours a day. And like, yes, that is true. But like that may, since my job is not to work out and sometimes it also wants me to do work, like that can create real challenges. And so I think it's really important that we're nuanced in how we sort of think about taking folks off treatment and supporting them in different dynamics.
Okay, great discussion here. Let's talk about real ROI, okay, which is what we've been alluding to, and economic impact. Do any of you have any data from real world, clients, examples? Obviously, you don't have to say who they are, but that's the big question. What's the ROI? Does anybody want to jump in and share anything positive or negative?
I'll start because I've been looking at this. There's actually a ton of data, and you just have to figure out how to interpret them. So from my perspective, there are various type of models to estimate ROI. The three that we use, or I use personally as well. The first one is these health economic models. This is essentially what you're doing there. You're estimating direct and indirect change in healthcare utilization and cost. That includes productivity and absenteeism, and the impact it has on the treatment. So these type of models include things like cost effectiveness analysis and budget impact analysis to estimate the change in cost over time. The second type of model is epidemiological model, and that's where you're looking at change in prevalence, diagnosis, morbidity, mortality associated with obesity compared to real world evidence. And then the last one is actually real world evidence models, which we're looking at paid claims, EMR data, patient-reported data to estimate the change in utilization and outcomes over time. So the ones that we recently did, Milliman did several health economics studies actually. And I think they're mostly published. One is used by Medicare. So what we did here is in the health economic model, you're looking at prior studies that looked at cost offset and applying it to paid claims, utilization, adherence, the price of the medicine, and you're running that model to estimate by line of business. So you separate commercial, Medicare, Medicaid, respectively, and you're running it to see what will happen over time. When do you hit the positive ROI? And we did a 1 for 5-year study for commercial and Medicaid, and I think it was a 10-year one for Medicare. And what we're seeing is that in this particular study that we looked at, we identified patients who are diagnosed with obesity, but they had no other condition, meaning they don't have diabetes specifically. They're not taking a GLP-1 for any other condition, specifically diabetes. And so when you look at that population and you track them and you measure the ROI over time, what we found was they became positive in year 5. in the commercial plan. And again, these are patients without any diabetes. These are just obese patients who are patients who are diagnosed with obesity. When you look at other studies now where you segment the population, getting to Elena's point earlier, now more high-risk patients. So now instead of just looking at just the patient diagnosed with obesity with no other risk, when you look at the patient who are higher risk, we see ROI faster within 1 to 2 years. So patients with cardiovascular risk, we see ROI much faster. So there's the two studies that I really liked. That one was published in 2019. It was done using a large insurance claims data set, and was looking at utilization and cost for patients who was treated with liraglutide. So this is an older medicine. This is before the new medicine came out. So we had data before the new GLP-1s came out. And what it was is it was a real world evidence study, and it looked at healthcare utilization and cost among patients who were treated with liraglutide for obesity. And then what it found was that these patients had significantly lower healthcare costs and utilization compared to a matched control group. And the lower utilization was specifically for hospitalization and ER visits. So that already had some preliminary, that's a good directional data to say there's definitely value here. A more recent one, this one here was more of a health economics study when they looked at semaglutide, 2.4 milligram. That also, this was published into 2021. And it also showed that when you look at the cost effectiveness of comparing patients who were treated with the medicine plus behavioral lifestyle versus those who were just treated with just behavioral lifestyle, you saw a reduction in total healthcare spend. On average, these studies, we're seeing 20 to 40%, so 20 to 40% reduction in total cost of care for the studied population compared to baseline. And the percentage vary because of what I said earlier. So it's based on the patient risk profile. So the higher the patient risk profile, for example, patients with cardiovascular risk, you're going to probably see the higher saving percent. So that is over a 5-year period. So there's been a ton of studies. I think we need more. We need more around the real world evidence, especially with the number of patients who have been treated recently. And I know some of the plan sponsor right now are trying to measure that with limited data they have. But I think even with 1-year data, we should see some KPIs that definitely tell us a story here. But it'll come down to patient segmentation, and how you cover these drugs and who actually receive them and who actually are receiving the behavioral health modification support. If you can get that combination right, the ROI is guaranteed, from my perspective.
Yeah, so I want to build on AJ's point, because while I deeply believe that there is sort of lots of associated value on productivity, workers' comp, disability, broadly, even in healthcare, we know that sort of solid engagement can have a lot of sort of downstream valuable impacts. We focus on basically like the hard numbers. So essentially, what do you see on claims? And we tend to actually focus on existing costs. So where can I sort of take existing costs and reduce those costs? Now, I will say we do offer individuals, we do offer sort of companies we work with a perspective on what we term rising risk. But I'll get to that in a second. So on existing costs, it is very much segmentation. So what we've actually done, I think this is comparable to what AJ talked about, is if you look at the body of research, we sort of took a step back from what is the specific treatment and translated various treatment data into what was the weight reduction driven, right? And then what was the sort of associated cost reduction on incremental costs associated with different conditions, right? And so to me, that's a really impactful way to think about it, because we know at sort of a population level, right, that someone at class 3 obesity is about 2.5 or 3 times the cost of someone at optimal weight. So said another way, if someone at optimal weight costs $500 a month, someone with class 3 obesity costs, anywhere close to, let's say, $1,500, right, a month. And so you have a potential pool of $1,000 linked to specific condition sets or essentially exacerbations of conditions that is a potential to save on. And so what we're trying to do is then allocate that 1,000 incremental dollars to the specific conditions, understand what treatment type, can be applied, what's the weight reduction that it drives, and then what is actually the associated cost reduction. To AJ's point, frankly, the higher you go up in, BMI, but BMI is a proxy for comorbidity, the more incremental cost you have. And frankly, the more that incremental cost is driven by obesity. And so actually, the more material reductions in obesity drive a higher percent reduction in that. And so that's sort of what we model out. And then I think to AJ's point, because I probably spent too much of my life with actuaries who are like, is it regression to the mean? And you're like, it's hard to say it's regression to the mean if they've had the same rising cost for 5 years. But what you can actually also look at there is, and we really focus on this to AJ's point of year one, is sort of measurable leading indicators that it's working. So just to be clear, for most individuals, RX and DME, right? So DME, including things like CPAP machines, accounts for about 30% of their total cost of care. But it's a leading indicator, right? So a lot of times, why is someone heading to the ER or inpatient? There's an exacerbation, either because they didn't stay on that treatment or the treatment started being insufficient as they essentially, progressed in disease state. And so what we're generally looking at is, can we identify the cohort of folks where there's sufficient ROI? And I want to be clear, sufficient ROI in obesity treatment, not just GLPs. So sufficient ROI maybe on bariatric surgery for some people, Kissimmee for others, semaglutide for others, tirzepatide for others, right? Like a whole host of different treatments. But then what you also want to see is when you start treating that you have that leading indicator, that you're seeing the weight reduction, but you're also seeing the stabilization around both biometrics and sort of patient reported outcomes that enable you to take people off certain treatments, but then reduce the likelihood of those exacerbations that were occurring regularly and reduce your total cost of care. And so we do see about 20 to 30% of people, depending on population, of those with obesity where there is near-term ROI on treatment. And I would say the most powerful thing we see is oftentimes the individuals where there is very high ROI from treatment, there's a reason that it feels like they're being particularly undertreated. So in one population, it was a lot of actually women with an anxiety or depression comorbidity, right? And so potential that sort of providers were less excited, let's say, to engage with them. And so they weren't getting some of the treatment dynamics. In other populations, we saw a lot of men with sort of more mechanical conditions. So there's a lot of times sort of cohorts and sort of dynamics going on that's leading to that. And then I'll say the final piece on this is this concept of rising risk, because I think AJ and I come at this at the same point. People want proof. So they want to see, last year I paid X, this year I'm paying less, or hopefully next year I'm paying less. But there's also a dynamic. We actually have predictive modeling on where is their rising risk. In other words, where the underlying medical condition that that individual is coded for and their cost are below trend line. And so even without exacerbation, that's actually negative reversion to the mean for you. And then very high probability of that person also accelerating into disease progression. And so answer here is like, we're seeing ROI potential and analysis, but also as we're treating, we're seeing people come off medications, reduce some of their related support needs, improve their underlying sort of biometrics and well-being. That all translates to lower cost and ROI.
Yeah. If I leave you with two metrics, so to get to the positive ROI, meaning a decrease in total cost of care, two metrics have to be hit. The first is patients need to lose 10 to 20% of body weight, which is possible with the medicine. However, more importantly, you have to see a sustained weight loss. That's the adherence part. That's the sustainability and durability. And if you achieve the 10 to 20% and sustainability, the sustained weight loss over 2 years, that's where you see positive ROI in any plan sponsor. From the model.
So we only have a couple of minutes left, but I did want to get in this one last question from the audience. For those of you who need to drop it exactly one go, we may go a minute or two over, but there is a big controversy now around compounded semaglutide. And so one of our attendees asked that he or she recommends not to use this due to potential safety concerns, but the reduced price and is an incentive, right? It's a huge driver for people. So what's your thought on the issue of compounded semaglutide? Am I saying it right? No.
Semaglutide, you said.
Yeah, semaglutide.
I mean, from my perspective, the FDA give a reason for compounders to do this based on, two criteria based on supply issue. And I think if there's a supply issue and the pharmacy is accredited, it's not coming from some pharmacy that's getting medication outside of the supply chain, then I think compounding is, a decision that plan sponsor can make, taking that risk. However, if there is no supply issue and you don't have any type of confidence on who this compound pharmacy is and where the pedigree of that supply chain acquisition of this medicine, I would not take the risk. So it comes down to doing your due diligence and recognizing when it's appropriate to do compounding. And the FDA is very clear on when you can do compounding. There's two scenarios based on supply chain issues, meaning the availability of the medicine.
So we don't support compounded medications. Our view is we have a responsibility to our members and we're not willing to take sort of the safety risk. And I would say I actually also very strongly feel that there is a host of other treatments that are safe and effective at different levels, right? And so, AJ talked about needing to hit 10 to 15%. Look, we have someone on program right now, 80 BMI, 15% is woefully insufficient. So our view is that you need to get the right level of weight reduction for the acuity of the individual you're treating. And there is a lot of people that could be successful at 8 to 10%, and then a lot of people that need 25%, right? And so I think our view, and this is why I deeply believe in value-based care, is I do wish the branded drug prices would come down, but even in today's sort of net price world, you can get to total ROI without trading on safety. And I believe that's just like deeply a responsibility we have to our members. And, we all have to sort of the folks we support.
Okay. Well, we are exactly at 1:00 and we could keep talking for hours because I know you all are passionate about this topic, but I want to thank you, Matt, Alina, and AJ for joining DHNY today for this session. And I know we got a question around posting Milliman reports. I don't know if they are public or not, but if they are, we will. Yeah. Okay, we'll put those in our recap report to folks on the webinar. So thank you all and have a great rest of the afternoon.